Checking. I'm checking. Hello. Hello. Checking. Yeah. Hope I'm audible. Watching your chats on other content. So anything, any doubt you have, you can post in the chat box. Okay. There is a chat box in the Zoom. You can utilize it. And you can post the chat questions there so that I can clarify your doubts when we are going on discussion. So very fast, I could recall some of the questions which are asked in this exam. So I hope it will be good evening, Raj. Welcome. So with the help of my students from various groups like Telegram, Facebook, and other places, we have collected some important questions. We will see those questions now, one by one. This session is also live in YouTube. So 1 second. Okay, it's fine. So any doubts or any queries, I'm watching in another device. You can always post while discussing, and any question you feel it is not the exact question also, you can tell me, because whatever I have collected from the students only, I'm coming here so that I will modify those questions in the next discussion. It's a fast recall session. You made it very fast. In such a way, it will be interesting only when you have a fast session. So I'll be discussing the essential concepts which will be useful for NEET exams also. So it's a 2022 May surgery questions. And there's a very important disclaimer before starting a discussion. The questions discussed here are model questions and not the original questions, as we are well aware of the do not disclosure. And any questions looking similar are purely coincidental and not a direct repeat. Okay. So let us start the discussion now. 57-year-old unmarried female nulliparous woman having regular intercourse but on oral contraceptive pills had a mother cancer breast 50 years of age. Sister had a cancer at 40 years of age. What advice will you make next? So what is the answer you all made? Yes, good evening, Nitya. Good evening, Nataraj. Welcome. What is the next step you will make? The important point here is this patient is a 37-year-old lady, so very young female. So it's a very young female. So she has a risk of developing familial breast cancers. So you all know very well that one of the common causes of familial breast cancer is BRCA1 and BRCA2 mutations are the two important mutations which can cause cancer breast. So I feel in this question, the examiner wants to identify the BRCA mutation, and I searched for the references. So yes, breast cancer, ovarian cancer, there is a direct line from Sabiston. Okay, the answer is C. There is a direct answer line for this question from Sabiston. Sabiston, page number 823. There is a model known as Couch model predicts risk of mutation in BRCA1 gene. So BRCA Pro model is another model, but Couch model is one model which is predicting. I hope you all know the other models which are used for predicting cancer breast. Can you tell me what are the other models? They are Gale model, Class model, or the various models used for defining the patient as high risk cases of cancer breast. Can you tell me high risk cancer breast patients, when will you start screening? When will you start screening for regular patients? When will you start screening for high risk patients? Very important basic question, a NEET PG level question. For a high risk patient, I want you to answer so that it will be better. Okay, high risk patients, what will be the answer? high risk cases will be, the answer is at 30 years. Okay, not 35, it is at 30 years. In regular patients, it will be started at 40 years. And in high risk patients, we will use MRI for screening. In regular screening, we use mammography for screening. Okay, so mammography is used for regular screening purpose and MRI is used for other people. Okay. Yes, stopping OCP is not going to change the patient going for I want you to know why their OCP is mentioned. I want you to know here. The reason the OCP is not mentioned to make it stop. The questions, every question in INI set exam, you should think very deep. She is a nulliparous woman. You should not think she is nulliparous because of some other reasons, is some hormone problem or something. She is on OCP. That is why she is nulliparous and having regular intercourse. Because some of you might think nulliparous is a risk of nulliparous or absent childbirth is a risk of cancer. They are mentioning all the risk factors. So all the risk factors they are mentioning, but what is advised as a next step is to look for BRCA testing will be the most important next step. So stopping OCP is not going to reduce her cancer breast. And this question, I feel the answer will be more or less, it will be 3. So answer will be more or less, it will be a genetic counseling because they want you to understand there is a problem in the family. So from the family history, they want you to go on to the step of making a BRCA testing. Because once the BRCA1 testing is done, that is going to change the entire treatment module. I hope you know what is the treatment for a BRCA1. If she is BRCA1, what will be the treatment? If she becomes BRCA1, what will be the treatment for this lady? She will undergo a prophylactic mastectomy of both breasts. Prophylactic bilateral mastectomy should be done. And if it is going to be a BRCA1 patient, we have to go for a MRI. Okay, we have to go for a MRI. So these are the essential things. Instead of mammography, we have to go for a MRI. So all these are essential points I want you to remember in this issue. Okay, please remember this is a question more favoring and targeting genetic counseling of BRCA. And this is a direct paragraph from Subster. So indications for consideration of genetic testing include breast cancer diagnosed before age of 50, bilateral breast cancer, breast and ovarian cancer in the same individual, because the second common cancer in BRCA mutation is ovarian cancer, breast cancer in the men, and family history. See, this is a line which is mentioned in this question, very clearly mentioned line. So family history, maternal or paternal of 2 or more individuals with the breast and ovarian cancer, a close male relative with breast cancer, close relative with the early onset of breast and ovarian cancer, also a known case of BRCA mutation in the family, we have to consider for genetic testing. So this question is more favorable for genetic testing, which is the next important step that should be done. OCP, by stopping the OCP or by doing a mammography, yes, all are going to be useful, but which is going to be the next important step is to look for BRCA testing. That is very important, okay? So this is a classical question. The next second question is, don't worry, I am discussing may not be the perfect examiner's key. They might be having their own key. You all know very well about the AIIMS examiners. They follow the protocol what is used in their institute. And most of these questions will be very well answered by the AIIMS residents as well as AIIMS postgraduates. We'll be getting the exact questions from them soon and we'll be discussing again. So this is a very classical question. On 30 years, male had a blunt injury to the abdomen. No blood at the tip of meatus. So blood at urethral meatus, what does it signify? If there is a blood in urethral meatus, it means what injury? It is an urethral injury. So please remember, if there is no blood at urethral meatus, urethral injury is ruled out. Very important point. There is no urethral injury. So blood at urethral meatus is a classical finding of urethral injury. There is no blood at meatus means there is no urethral injury. Okay. So Foley's catheter was put, but urine was almost nil. So there is a, so okay, let it be a minimum drain also. Let it be minimum also. Let it be a minimum drain. So this answer has to be made with the classical image only. There are 2 causes of injury that they are nothing but one is suprapubic. This is a bladder. This is the peritoneum. Okay, this is a peritoneal reflection. There are 2 types of bladder injuries you should know here. One is intraperitoneal rupture of bladder. Please remember, one is intraperitoneal rupture of bladder. Another is extraperitoneal rupture of bladder. So intraperitoneal means the urine which is coming out will be going into the peritoneal cavity. So we'll be going to the peritoneal cavity and it will cause uremic peritonitis. Uremic peritonitis is the cause of this problem. So what is the most common cause of intraperitoneal rupture of bladder is iatrogenic. When doing some surgery, the gynecologist or the surgeon, when doing some surgery, they injure the bladder is the most common cause of uremic peritonitis. But blunt trauma in a patient who is having a full bladder can also get injury at the dome of bladder. At this place, there can be injury happening. Patient will be sick. They will have uremic peritonitis symptoms. On the other hand, extraperitoneal rupture of bladder is due to fracture of pelvis. It is also possible with the blunt injury abdomen. A fracture of pelvis can cause this. And in this condition, what happens is very interesting. The urine will not be going into the peritoneal cavity and they will be extravasating subcutaneously. They will extend up to the nipple level and to the thigh up to the Holden's line level. You have urine in the body. So therefore, in both the cases, if you put a catheter, urine will not come. Foley's catheter is put, it will enter the bladder, but urine will not come, or very little amount of urine which is remaining in the bladder may come. Otherwise, this is a classical case of bladder injury. So bladder injury, what is not done? SPC is not done because there won't be full bladder. First point, please remember, full bladder will not be there because it is a suprapubic catheterization can be done only when the bladder is full, especially when there is a urethral injury. Periurethral catheterization is already done. They already done a periurethral catheterization. It is not going to help. A bladder rupture is not going to be helped only with the periurethral catheterization. And if it is an intraperitoneal rupture, we must do a laparotomy. So interesting clinical question because the image is showing you like this. The contrast thrown through the Foley. I hope you see the Foley's catheter. There is a catheter put inside. Put into the catheter. The contrast is extravasating into the abdominal cavity should be noted in the image. That is a very important point. Packing and all are not advised. Packing, nephrostomy are all not advised. For your clarity, I will give you all the images. This is intraperitoneal rupture of bladder. This is extraperitoneal rupture of bladder. You can see there is a bladder. Patient has a fractured pelvis. Plate is applied and the urine is extravasating in these places. Okay, they are extravasating in these places. And in fact, if extraperitoneal rupture of bladder is seen, it is mostly associated with what other injury? It is associated with membranous urethral injury. It will be associated with membranous urethral injury. Please remember that. So if there is an extraperitoneal injury, it may be associated with membranous urethral injury also. And there will be a shape of bladder like this known as teardrop bladder. Can you see? This is a teardrop bladder seen. This is a teardrop bladder which can be seen in those patients. So treatment of extraperitoneal rupture of bladder is, if the question is treatment of extraperitoneal rupture of bladder, answer will be 2. So this question, you have to tell the answer exactly by seeing the image. Because extraperitoneal rupture of bladder, the treatment is periurethral catheterization is enough, nothing else needed. Whereas intraperitoneal rupture of bladder, we need to do laparotomy. Simple question, clear-cut concepts directly taken from Bailey and Love. This question is not from any other book except Bailey. So Bailey says intraperitoneal rupture, laparotomy. Extraperitoneal rupture, put catheter. That's all, nothing else. Okay. If it is an urethral injury, you go for SPC. So each point is very clear. SPC done for urethral injuries. So this case is not an urethral injury because there is no blood at the tip of meatus. So you should understand this concept clearly before answering this question. Then only you can answer this question. And in fact, you can understand this image. So it is an image showing you retrograde cystogram image. Okay. So through the urethra, we are inserting contrast and seeing the finding. Okay. This cannot be a bladder plus urethral injury. That is why they have mentioned no blood at tip of meatus. In national board examinations as well as AIMS examination, they don't give unwanted history. Please remember, they won't give unwanted history. Every word in the history will have some significance. That significance you have to find out. That is the importance of the clinical based questions. And that is why you are given 200 questions for 3 hours in 3.5 hours for national board exam. So you should think it 2-3 times before answering the questions. Okay. So now, this time we have seen so many questions from SWATs. So previously they never used to ask questions from SWATs, 11th edition. This year they have asked a lot of questions from SWATs which are exclusively found in SWATs. This is a classical question only seen in SWOTs, not in Bailey, not in Sabiston. Difference between split skin graft and a full thickness graft. Correct statement is, okay, split skin graft and full thickness graft. What is the correct statement? Okay, I'm just watching the chats. Primary contraction means, for example, I am putting a graft. Okay, I am putting a graft like this. Today I am doing a split skin graft like this. So primary contraction means within 2 days to 3 days, it will go for a contracture like this. If I put a graft like this, it will shrink and it will go for contracture like this. That is known as primary contraction. Secondary contraction is I put a graft like this. It will be normal for some months. After few months, slowly the contracture happens. That is secondary contracture. So primary contraction is not seen with SSG. Please remember, it is not seen with SSG. It is secondary contraction seen with SSG. Primary contraction more with full thickness graft and thick SSG. So there are 3 types of split skin graft from SWOTs. So the split skin graft can be divided into SSG can be divided into 3 types. The one which is 0.006 to 0.012 inches, 0.012 to 0.18 inches, 0.018 to 0.024 inches. So these are the thickness, the inches of thickness. This is Thiersch grafting, which we are doing commonly. So Thiersch grafting is the one which is, we call it as SSG skin grafting, which is less common for primary contracture, more common for secondary contractures. Secondary contractures. I'll show you the secondary contracture now. So this is a classical secondary contracture following a skin grafting. Can you see here? This is a partial thickness graft. It has gone for a secondary contraction after a few months. You can see split skin graft, Thiersch graft being done. It has gone for a contracture after a few months. This is secondary contraction. But initially, there will be no primary contraction. Primary contraction, please see this classical table. This question is taken from this table in SWOTs. So this is a table in SWOTs. Answer is 2nd and 3 are 2 and 3 are correct. So secondary contraction more with SSG, primary contraction more with full thickness graft. Okay. See this interesting table. Primary contraction is common with full thickness skin grafting and split thickness graft, which is thick graft. Okay. Primary contraction is seen with these two. Secondary contraction is common with partial thickness split skin graft. This is Thiersch graft. So this is very important table. You can get in future questions from this in INI set. Okay. So these are the grafts mentioned in SWOTs. Thin graft is 0.06 to 0.12 inches. Blair and Brown is 0.12 to 0.18 inches. Thick Paget is 0.18 to 0.24 inches. So please remember all these questions which I'm discussing are already discussed in DocTutorials. I don't want to repeat again and again. This is there in our video lecture. This is there in video lecture because all the concepts are completely discussed. So you can wonder how we are able to do this discussion within 4 hours to 5 hours after completing the exam, because most of the questions, 90% of the questions are directly from our lectures and from our surgery 6-hour notes. So that is why I could make them easy, and all these are there in the material. Okay, these questions are there in the material. So you can see Thiersch graft, Blair and Brown, Paget, 0.06 to 0.12, 0.12 to 0.18, 0.1 to 0.24. So thick grafts will have less secondary contraction, more primary contraction. So you remember only one. I request you to remember partial thickness Thiersch graft will have more of what contraction? More of secondary contraction. You remember this alone, then you can answer all the questions. Okay, with this you can answer all the questions. So another question from directly taken from SWOTs. Again, this is another question from SWOTs. Nutritional complications are more with which fistula? Can you tell me the answer? Yes. Which fistula will have more nutritional complications? Anybody? Watching your chat, anybody can you tell me what is the nutritional complication? Yes, very good, Nataraj, very good. That is a duodenal fistula. So the question, the line given from SWOTs is proximal small intestine fistulas. Proximal small intestine fistulas will have high output. Please don't forget this. Will have high output. And because of high output, there is a metabolic, electrolyte, and nutritional complications. All are more with this, more common with this. It's a direct line. The loss of enteric luminal contents, particularly from high output fistulas originating from the proximal small intestine, result in dehydration, electrolyte abnormality, and malnutrition. So the answer here is very classical answer from duodenal fistula. This is a simple neat PG question. So the fistulas which will not heal is given by a mnemonic known as FRIENDS. What does FRIENDS stands for? F for foreign body in the tract. So I hope you know what is enterocutaneous fistula. Enterocutaneous fistula means connection from the bowel to the skin like this. So when it will not heal, usually it will heal in 6 weeks. What are the causes of non-healing? For F for foreign body in the tract, R for radiotherapy, I for inflammatory bowel disease, E for epithelialized tract, N for neoplasia, D for distal obstruction, and S for short tract, less than 2.5 centimeter tract. So foreign body, radiotherapy, inflammatory bowel disease, epithelialization, neoplasia, distal obstruction, short tracts will not heal in enterocutaneous fistulas. This is a very classical question from Swartz. The mnemonic is from Swartz. So another question taken directly. I'm telling you, most of the questions in INI set will be based on the practice and formalities followed in institute aims. That is why many times, many of the students from aims get the ranks, while students from other places are very difficult to get a rank in aims. So the aims residents are easy to get a rank there because many questions they don't read. Just by seeing the question, they know what is the protocol. This is the protocol. So when you go and search for this question in all over Sabiston, Bailey, Swartz, nowhere the answer is clearly given. But this is a thing they follow there regularly. Okay, patient is on tamoxifen after a breast cancer surgery. Very simple, all of you know very well. Tamoxifen is an anti-estrogen therapy given for estrogen receptor positive females for minimum 5 years. Okay, it is given minimum for 5 years. So there are new trials which have come now that has advised to use it minimum for how many years now? Minimum now, what is the latest advice? There are so many trials like Atlas trial, so many trials have come. They are advising to use it for 10 years now. Now the latest answer is very good, Vijay Paul, that is correct. So now the advice is to use it for 10 years. Now this lady has come to you for around 5 years. She was on tamoxifen and she is now want to conceive. What will you do now? So this question is very classical question from this journal. Okay, this is a journal explaining you. Tamoxifen when given should be stopped during pregnancy because it is teratogenic to the babies. It should be stopped 2 months before getting conceived. So the best answer here should be 1 month before is the correct answer. Very good, Vijay Paul. That is Atlas trial. Very good. That is an Atlas trial. I think you are a NEET SS aspirant. So Atlas trial is a trial to change it into 10 years from 5 years. From 5 years, they changed it to 3 years. So 3 months option is there means better to go for 3 months option. So 3 months before is the best option if it is there in the exam. I didn't get in the recall that question, so I'm going for that. So if there is a 3 months before, should be stopped before getting conceived. This is teratogenic. There are so many stillbirths. So ideal 2 months is given in this paper. So 2 months is given in this paper to stop this drug before. It's not, this question is totally not available in any of our standard textbooks and we have not discussed this before. This is a new question asked in the exam. So should be informed about the washout period of 2 months before conceiving. Okay, this is the answer here. I don't know, this question is being a repeat question. Why there are so many confusion among the students? This question is a multiple times repeated question, not 1 time or 2 times. The same image has come in the exam, AIMS exam, previous old national board exams. Every year we get this exam question. This is known as cholesterolosis, also known as strawberry gallbladder. What are these yellow things? They are nothing but small cholesterol stones. Cholesterol stones. They are nothing but small cholesterol stones and they are known as strawberry gallbladder. This is a direct image from Bailian law. This is the image of gallbladder. So this is the direct image of Bailian law, looking like a strawberry. This question and all, if you make mistake, there will be no excuse. These are 100 times repeat question and you should never make a doubt in these type of questions. Another question which you should never make a mistake. These are very simple, basic questions. When I take esophagus chapter, I always used to tell when the examiner wants to ask questions from GIT, the more focus of the examiners will be on esophagus. They will ask only questions from esophagus more. So you can see naturally another question. So both cholesterol and strawberry gallbladder are present in the paper. That means it's a gross mistake by the examiner. People told me strawberry cholelithiasis. So this is actually a interior of the strawberry gallbladder cholesterosis. Okay, cholesterosis. This is a direct line from Familial law. I don't know whether they both are given or not, but this is the best answer to go for is a strawberry gallbladder. It's a very famous question. Okay. What is the investigation? See, the examiners, in fact, already the question is looking easy. The examiners will confuse you, make more complicated the questions which are being asked simple way. What is the investigation to diagnose this case? This is a case of bird's beak appearance showing you Achalasia cardia. I'm not sure about all the exam choices, but I'm sure about the areas. I am discussing this question not to discuss the questions, but I want to tell you what are the areas which are very important for exams, for future exams also. So Achalasia cardia is a left and right, straight and back, 100 times asked repeat question. You should never have a doubt. Investigation of choices, high resolution manometry. So high resolution manometry of Achalasia cardia. So can you tell me? The most common type of achalasia is type 1 achalasia. Please tell me the high resolution manometry findings of type 1 achalasia. Number 1, what about peristalsis? It is absent peristalsis. Findings in high resolution manometry. There will be absent peristalsis. Number 2, what about DCI? I hope you know what is DCI. Distal contractile integrity is less than 100 millimeters mercury centimeters seconds. 3, integrated relaxation pressure is more than 15 millimeters mercury. So this is type 1 classical achalasia. Classical achalasia, known as classical achalasia, is the most common type. Is the most common type. Type 2 will have one interesting finding on topography. What is the finding? That is again a repeat MCQ. It will have an interesting finding. Type 2 is vigorous. The name is removed, but it is a vigorous type in which DCI is more than 450 millimeters mercury centimeters seconds, and they will have an isobaric contour. They will have isobaric contour. I think some of you will be attending in YouTube. Those guys who are attending in YouTube, you can join the Zoom session also. The Zoom session password is here. So you can use this Zoom session password and you can join the Zoom session also. Instead of attending the session in live in YouTube, you can always come and join directly, because I'm using the Zoom queries here. I'm not using the YouTube queries. So you can come and ask your queries in this session. So if you are using the Zoom, you can join in your Zoom session. Very good. Doc, that is a pan-esophageal pressurization. The finding will be a isobaric contour. Vijay Paul, type 3 is spastic. Type 2 is vigorous. Type 3 is spastic. I'm not going to that. Pan-esophageal pressurization at isobaric contour of 30 millimeters mercury is seen in type 2 achalasia as well as type 3, but more common with type 2. So please join the Zoom link and join this session from the Zoom link. So we are discussing around 22 to 23 questions. We are going to discuss. So Sasidharan is telling that question was a case of symptomatic cholelithiasis and cholecystectomy done. Identify, yes, whatever it is. Yes, I will note it. It's a symptomatic cholelithiasis. But image, is there any doubt in this image? This is the usual image they'll ask you. They won't ask anything else. That will be a strawberry gallbladder only. It cannot be a cancer gallbladder, or it cannot be a polyps. It can be either a strawberry gallbladder or multiple stones should be, moving stones will be there. Not like this. These are fixed. These are fixed, studded. They are studded in the wall, mucosal wall. Okay. This is again a question from pathology or maybe from surgery. We don't know, but I'm discussing in surgery because I used to take classes on blood bank. Blood from donor in Indian setup is usually screened for all except. What is it? Yes, very good. Dengue. In dengue is not screened in India. We screen for malaria, hepatitis B virus, hepatitis C virus, HIV 1 and 2, but not for dengue. So it's a straightforward, simple question. In UK, they do for hepatitis B virus C virus, HIV 1 and 2, and syphilis. In India, along with this, we also do for malaria. In Western countries, sometimes they screen for Creutzfeldt-Jakob disease. So to avoid this Creutzfeldt-Jakob disease transmission, they do leukodepletion. Please remember this point. So leukodepletion means what? WBC filtering. WBC filtering is done in blood donation time to prevent two things. One is Creutzfeldt-Jakob disease in Western countries. And another important reason is the most common reason we use in India. That is what is the most common complication of blood transfusion? Most common complication of blood transfusion. Can you tell me? It is non-hemolytic. Please remember, it is non-hemolytic transfusion reaction. Yes, it's a fever, but non-hemolytic transfusion reaction, which is a febrile reaction caused by WBC. Okay, it is caused by WBC. That is why we have to use leukocyte reduction filter. Is an old MCQ image-based question of AIMS. Okay, leukocyte reduction filter. Please remember that. So this question, I have an incomplete choice. I hope you will complete this choice now. Grade 3 splenic laceration after a blunt trauma injury. Patient is on non-operative treatment. On second day, for what reason you take the patient? Second day, or I'm taking the patient for laparotomy. So non-operative treatment is the latest gold standard for all injuries, all blunt abdominal organ injuries, like solid organ injuries. Non-operative treatment is a gold standard treatment for hemodynamically stable cases. So any patient who is stable, we will treat by non-operative management. So when will I take a patient for surgery? The following are the reasons I will take the patient for surgery. Number 1, yes, very good. Presence of pneumoperitoneum. Pneumoperitoneum means what? What does it signify? Pneumoperitoneum signifies there is a bowel injury. So there is no conservative treatment for bowel injury. Number 1. Serial fall in hemoglobin. Not this one value I cannot confirm. I am going to do laparotomy. I cannot confirm from one value. I have to do serial, because that is a value which is because of the slow bleeding. Patient is unstable, okay, but serial, today it is 12, tomorrow it is 10, day after tomorrow it is 8, after that it is 6, then I will do surgery. Otherwise, I won't do surgery. Serial fall in hemoglobin. Patient becomes deteriorated. Patient becomes deteriorated. Number 4, I am doing laparotomy for some other injuries. Some other injuries. For some other injuries, will it include extraperitoneal rupture of bladder? I already told you extraperitoneal rupture of bladder does not need surgery. Only Foley's catheter is enough. See, same question is linking in multiple places. Just Foley's catheter is enough. No need of doing a surgery at all for extraperitoneal rupture of bladder. Presence of air in the presence of pneumoperitoneum is already given. No, there is 2 questions. Presence of pneumoperitoneum means air in the peritoneal cavity only. No, that is correct. Hollow viscous perforation. Anything else? I don't know the 4th option. The 4th option, what is given there, I don't know. Laparotomy was taken in this choices among the 3. Gallbladder distension. I don't know why they kept the gallbladder distension. So it cannot be an answer for this laparotomy. Gallbladder distension is not a reason for doing a laparotomy. If it is there in another option of gallbladder distension, definitely it is not an option. Okay. So stable cases, I will do non-operative treatment. And I will plan for surgery when there is a serial fall in hemoglobin, when there is a pneumoperitoneum causing peritonitis, or patients becomes deteriorated, or some other injury when I'm opening, I will do laparotomy. So when I'm going to discharge the patient, very important INIZ question. A splenic trauma patient, non-operatively managed, is going to be discharged. For example, this is a patient who treated non-operative management. He is going to go home. He was there in my hospital for 2 weeks. I am discharging, go home, you are nothing to worry. Before discharging, I should do an investigation. What is that investigation to be done before discharge? That is going to change the entire management. What is it? Today I'm going to discharge. Yesterday I should have done this investigation. That is contrast enhanced CT abdomen. Very good. It is a contrast enhanced CT that will show you an interesting finding in some cases known as tumor blush. What do you mean by tumor blush? Tumor blush. What is tumor blush? tumor blush is nothing but pseudoaneurysm. Okay, it is not a leak actually. It is a pseudoaneurysm developed in the splenic artery. A pseudoaneurysms, I should go for a angioembolization. Angiocoil embolization should be done before discharging the patients. So please remember, tumor blush is an indication for intervention. So it is a failure of non-operative management. So the answer for tumor blush is it is a failure of non-operative management. The treatment which I did is failed completely. There is a failure of non-operative management. Okay, please remember this point. So I don't think this question is a surgery question. Again, this is a microbiology question. Human papilloma virus is implicated commonly in the following except. So this, I think, multiple choice question. It is implicated in all the virus infections given in this A, B, C, D. It is implicated. Probably this is a question taken from microbiology exam paper. Cervical cancer is the most important cancer. It is associated. Anal cancer is second important. Two important cancers associated are cervical, anal, and head and neck. Oral, oropharyngeal cancers. Penile, vaginal, vulval cancers. If at all you want to go for less, means you have to go for laryngeal papillomatosis cancer is the except I can put, but otherwise cervical, oropharyngeal, anal, every cancer it is associated very highly. Okay, so in fact laryngeal cancer is also mentioned in some studies. Please go through this viruses causing cancer in microbiology. This is a question from viruses causing cancer. Viruses associated with malignancy. In this, I want to focus on important virus, hepatitis C virus. What are its association? It is associated with hepatic cancer and non-Hodgkin's lymphoma. Please remember, hepatitis C virus associated with non-Hodgkin's lymphoma and hepatitis cancer. Okay, oral cancers it can cause. Oral cancer is associated with human papilloma virus. I'm telling you this question you should verify from the microbiologist. That will be better answer because this question might be taken directly from microbiology books only. So leave it. Oral cancers, it is associated. Laryngeal cancers is mentioned in this study, in this paper. So this is a classical surgery question which a final MBBS student can easily answer. This is a deep ulcer in the heel of the patient. So first thing, this ulcer in this place in the heel, you should first of all remove this first one. Positive Trendelenburg test is a feature of what? It is a feature of venous ulcer. So first choice is excluded. The fourth choice is also excluded. Pain on passive movement of calf muscles is a feature of DVT, deep vein thrombosis. So that is also ruled out. Deep vein thrombosis, Homan sign, Moses sign, that is also ruled out. So venous ulcer and varicose ulcer both are nearly same, but DVT causing ulcer is known as venous ulcer. Varicose vein causing ulcer is known as varicose ulcer. Both are ruled out in A and D choices. So if at all it is a venous ulcer, what is the most common site of venous ulcer? That is the first important question. It is seen most commonly on the medial malleolus. That is the first important point. Okay, medial malleolus. Yes, it's a gaiter area. Gaiter means when you're riding a horse, you fix the gaiter on the ankle. That is a gaiter area. Medial malleolus is the common site. This is a medial malleolus varicose ulcer seen in this place. Okay, this is a place of varicose vein ulcer. So what are the other ulcers you know? So this is number one ruled out. So the second important ulcer is that D choice, decreased sensation. What do you call that ulcer as? Can you tell me? What is ulcer caused by decreased sensation means? It is a neuropathic ulcer. Neuropathic ulcer is nothing but due to loss of sensation. So where is this ulcer commonly seen? That is the catch point here. It will be seen more commonly on the bony prominences, all the bony prominences, like heel, over the great toe. So this is very clear. So diabetic patient is given mean there is no discussion at all. It is a case of decreased sensation. Diabetic patients are the most common to get a neuropathic ulcer. So neuropathy is one of the important pathology behind this type of ulcers. There is one more ulcer which can confuse you, especially final MBBS students. You should know there is another ulcer known as tropic ulcer. What is this tropic ulcer? Please remember, tropic ulcer is an ulcer of mixture. It is a mixture of ulcer. It is containing impaired nutrition, loss of blood supply, neurological deficit. Altogether, they are also known as neuropathic or neurotropic ulcer, but they have loss of blood supply. So diabetes mellitus, stapes, leprosy, peripheral. Now the problem comes. Will there be absent pulses? Yes, there can be absent pulses, but important best answer, single answer is C. B also can be seen, but if there is an only arterial ulcer, there is another topic known as arterial ulcers. Example of these diseases, can you tell me what are the causes of arterial ulcers like Buerger's, peripheral vascular disease? These guys will have ulcer on the dorsum of the foot like this. Arterial ulcers will have on the dorsal aspect, and very important, they will have no pulsation, posterior tibial artery. Yes, no, whichever is the best, you should know, understand the INI common entrance test fellows. The paper will be like that only. They will make many times 2 questions will be like looking like correct. Many times we cannot even the faculties, most of the time we could not find out the correct answers. That is why I'm telling you, these are the questions which are very, very commonly practiced questions by the residents there. Most of these papers are made in such a way their residents will answer even without reading the PG entrance examination contents. That much they will answer. If you ask some house surgeon, they will answer all these questions just like that. They will tell, okay, this is a commonly seen image, this is our regular case, this is that answer, like that. They would have seen most of the questions. So this is, you will see the result. When the result comes now, you will see why there are so many toppers from NEET PG, but not from, they are not getting in AIMS. You will get the answer at the end of the result. So this is a dorsal aspect ulcer. So this is an ulcer seen in the dorsal aspect in arterial ulcers. So there is another question again from the esophagus. I hope you know there is another question in the esophagus. That is again, there is a, which investigation is not commonly used or less significant, giving a barium meal, barium swallow of esophagus was given, showing again bird's beak, which is no use in this list. Can you tell me which is no use? pH monitoring is not needed. pH monitoring is for GRD cases. Okay, manometry is needed. Upper GI scopy is done to rule out pseudoachalasia. What is pseudoachalasia? Can you tell me what is pseudoachalasia? Pseudoachalasia should be ruled out by doing an endoscopy. That is nothing but CA-OG junction tumors. Carcinoma in the OG junction can appear like pseudoachalasia. Sometimes cancer in the other places like lung cancer, breast cancer, all these things can cause pseudoachalasia features. But anyhow, upper GI scopy is always done in a case of achalasia before operating. Timed barium study is actual correct barium swallow. So that is at certain time we have to follow that to catch this motility disorders. Timed barium study is the investigation for motility disorders. All the motility disorders, we have to use a timed barium study. So this is not from Sabiston, it is from Shackelford. So the answer here is A is not the correct answer. B, C, D are correct answers. So which specimen is operated here? This is a classical question again. This is a classical question on Whipple specimen. Whipple specimen is asked even last year in FMG exam. So this is a specimen of Whipple's. So Whipple's specimen or Whipple surgery is going on here. So this is Whipple's specimen or Whipple's operation. Please understand what is it. I'm drawing the Whipple's operation in a simplified way. Understanding the anatomy is very important. This is the pancreas. This is the neck of pancreas. This is bile duct. This is gallbladder. This is the proximal bile duct. Now, if there is a cancer in the periampulla, number 1, periampullary cancer, or a cancer in the head of pancreas, HOP, head of pancreas, or in the distal bile duct, or in the duodenum. So in all these 4 places, the supply is same. Please remember the supply of lymphatics, blood supply, everything is same for these structures. Therefore, when I want to remove any one of these cancers, I have to go and cut distal to the stomach like this. The distal stomach, I have to remove the entire duodenum up to DJ flexure. I have to remove the head of pancreas up to tunnel of love. There is a tunnel of love containing portal vein. And I have to cut up to this CBD to CHT, common hepatic duct. I have to cut, remove the gallbladder. So this area is fully removed. This area is fully removed when I'm doing an operation. And finally, at the end of the operation, there will be stomach like this. There will be bile duct like this. There will be distal pancreas like this, and I will bring and anastomose the jejunum like this, 3 anastomoses. PJ, GJ, HJ, hepaticojejunostomy, gastrojejunostomy, pancreaticojejunostomy. So the answer here is distal CBD cancer, periampullary cancer, head of pancreas cancer, duodenum cancer only you do this operation. So what is there in the exam? If it is a distal cholangiocarcinoma, you can go. Otherwise, the best answer is CA, head of pancreas. Okay, this is a classical question. If it is a distal cholangiocarcinoma, it is correct. Otherwise, this is wrong. Only cholangiocarcinoma we cannot go, because intrahepatic cholangiocarcinomas, the answer will be different. The answer, best answer you should follow here is to go for CA, head of pancreas. So many of them are in the watching in this thing in YouTube. So chronic pancreatitis, we will never do a Whipple's. Some of them are from that area. I told. So patient was given. Patient has on and off jaundice. So classically, if there is an on and off jaundice, can you tell me what is the cause? On and off jaundice means you can easily come to a conclusion. What is it? There is no need of any discussion. Yes, periampullary cancer is the best answer in such cases. Periampullary cancer only will get waxing and banning of jaundice, and they will get bleeding associated with jaundice. They will get Thomas sign. What is Thomas sign in periampullary cancer? Thomas sign is silver stools. Silver stools. Please remember, these points are classical. If you have told me this point of on and off jaundice, I would have not even read the choices. I directly would have gone to periampullary cancer. Only periampullary cancer can get on and off jaundice. No other cancer can get an on and off jaundice. Please remember, it is due to sloughing of the ulcer or the cancer, the jaundice gets relieved. Again, it grows. It causes cancer. At the time of sloughing, the patient will get Thomas sign, silver stools. Okay. Most common ectopic tissue found in Meckel's diverticulum. Most common ectopic tissue found in Meckel's diverticulum. What is answer? Most common ectopic tissue found in Meckel's diverticulum is, first is gastric mucosa, second is pancreatic mucosa. These are the first two, but colonic also is seen. But they have given only two options. So go for gastric and pancreatic mucosa are the two common mucosa. No, thyroid is not seen in Meckel's. Not thyroid. Thyroid is not seen. Thyroid is not seen. Adrenals are not seen. Pancreatic, third colonic, fourth Brenner's glands. So important in this or significant one is gastric mucosa, because it will produce peptic ulcer disease due to H. pylori infection. Due to H. pylori infection, it can cause peptic ulcer disease and it can cause bleeding. That is a common presentation of Meckel's. Bleeding. Okay. Most common cancer in Meckel's diverticulum is a carcinoid tumor. Carcinoid tumor is the most common. Okay, carcinoid tumor. Please don't forget this point. Okay, carcinoid tumor. A patient developed loss of sensation in the root of penis after laparoscopic hernia surgery. Which of the following nerves would have been damaged? So I have been discussing this question very commonly. This usually in a laparoscopic tap abdominal surgery, transabdominal preperitoneal surgery, the most common nerve injured is what? It is lateral cutaneous nerve of thigh. But the point here is they didn't give the lateral cutaneous nerve supplies the gluteal muscles, gluteal skin. But the question given is very clear here. They have mentioned the features. Root of penis sensation is lost. So what is the answer here? I also thought the moment I saw this laparoscopic complication, answer will be lateral cutaneous thigh, but the answer is here it is iliohypogastric nerve. So ilioinguinal nerve was also there. Okay, better answer will be iliohypogastric nerve is most commonly injured in this, because it is again an applied anatomy question. So from anatomy faculty, you confirm what is supplying the root of penis. That is the answer here. So from the sources, iliohypogastric nerve gives two branches, lateral cutaneous and anterior cutaneous. Lateral cutaneous supplies gluteal skin, anterior cutaneous supplies suprapubic skin. So I hope the answer is iliohypogastric nerve. If ilioinguinal nerve is there, I'm not sure. Iliohypogastric becomes sensory. Iliohypogastric becomes sensory after entering the inguinal canal. Before entering the inguinal canal, it is muscle supply is also there. That is the reason when you injure iliohypogastric nerve in a case of appendicectomy, you will get a right direct hernia. Okay, you will get a right direct hernia. So in this question, the most common nerve they would have asked means I would have gone directly to lateral cutaneous nerve of thigh, but they didn't ask that. They have asked loss of sensation at the root of the penis. So I'm going to iliohypogastric nerves. Psoas abscess question is an incomplete question. I'm not sure whether the choices are correct or not. Psoas abscess is psoas muscle is a retroperitoneal muscle. So this is a vertebra. This psoas muscle is a retroperitoneal muscle like this. Retroperitoneal muscle like this. It crosses the inguinal ligament posteriorly, and this can get abscess very commonly due to multiple reasons. Any abscess in the psoas muscle area is known as psoas abscess. It can be fluctuant. If I press this way, I can feel the thing there. That's it. So this is known as cross fluctuation is present. So when you see these patients, they will be lying. The patients will be lying in a flexed hip. They will be lying with a flexed hip all the time. So when you try to extend, there will be pain during passive extension will be there. Part spine will be present. Part spine can present as psoas abscess true. Hematogenous spread in immunocompromised, all the answers are true here. So I don't know. Okay, then no problem. Lateral cutaneous nerve is not there in the option also is not a problem because the answer there is iliohypogastric nerve only. So don't worry about that question. Leave that question. It is iliohypogastric nerve that is commonly injured because it is applying the root of penis. So here all the questions, all the choices are correct. I don't know any change in that because psoas abscess is divided into primary abscess because of the infectious collection within the psoas muscle tracking from the venous blood from the lumbar spine. Secondary abscess can be due to infections from the concomitant structures like Crohn's disease, appendicitis, diverticulitis. All this can cause psoas abscess. So this is the picture showing you. Yes, in this I don't know whether the option D was most common cause in immunocompromised is hematogenous. That's what the hematogenous cause is also seen. Hematogenous cause of psoas abscess also is seen. Let me find out any reference because these are not from Bailey and Lau. Any other books they have put, I'll verify and tell you. So you can see the patient lying in a hip flexed, no restriction of movement, no pain on active movements, he will move. But pain on passive extension and internal rotation of hip. On internal rotation of the hip, there will be pain on passive extension and internal rotation of hip. So very simple, the easy question that is about the inflammatory bowel disease, differences between Crohn's disease and ulcerative colitis. So very simple, Crohn's disease has skip lesions, no doubt in that. Skip lesions are seen in Crohn's disease. Ulcerative colitis is a continuous involvement. And Crohn's disease is a disease involving transmural involvement seen, whereas ulcerative colitis involves partial thickness. You know very well, ulcerative colitis involves partial thickness. So mark the wrong statement was mentioned. Okay, mark the wrong statement. Crohn's disease correct. Childhood inflammatory bowel disease is genetic. Can you tell me what is the gene associated with the Crohn's disease? It is NOT2 gene or CORD gene. Is a gene associated with Crohn's disease. So many genes are discussed in Sabiston. May not be asked in NEET PG exam, but just remember inflammatory bowel disease is genetic, very common in childhood. Crohn's mucosal ulcerative colitis is transmural is wrong. Crohn's curable is totally wrong. The curable disease is ulcerative colitis. Crohn's disease is incurable. Okay. So whatever it is, correct statement, whichever is correct, A and B are correct, C and D are wrong. Okay. So C and D are wrong. So hereafter, I'm telling you, once you have completed the exam, don't worry about what has happened. So the purpose of writing the institute exams is not to feel guilty of making a correct answer or wrong answer and to go for a sleepless nights. The reason for writing exams is you should know what are the silly mistakes you are making in the exam hall, and you should now strengthen the 200 concepts that came in the exam. It's time now to strengthen the 200 areas. You got 200 questions. Those 200 question areas you should have thorough and you should have in fingertips. You should never ever make a mistake in these 200 questions. That's all. Otherwise, the purpose of this discussion is not to judge whether you have made correct or wrong. I'm telling you, because of getting a rank in INI set exam, I may not tell he's a very brilliant student, and those who are going to miss a rank in INI set is not going to be a low quality student, because the exam questions are going to be in such a way only 3 or 4 questions will decide the rankers in this INI set. So real rankers will be decided in the NEET PG exam. So please don't worry about whatever happened, what you wrote, whether it is a mistake or not. Now it's a time, 200 concepts, you should be thorough in the next 5 days to 6 days. Whatever questions being asked in the exam, these areas go and read depth. So for example, inflammatory bowel disease, there is an area asked. So question asked on Achalasia cardia. So like such areas, you should go and read at depth and understand the questions. Okay. So there will be no repeat questions, but there will be repeated areas. There will be repeated areas in National Board exam. Same areas will be again and again asked. So please remember, Crohn's disease is an incurable disease. Okay. Again, this may be an anatomy question, but surgery is also related. So I'm putting it as 20 ml. Volume of prostate is only 20 ml. And the prostate's zones is classified by Meckel as how many zones? Surgical zones of Meckel. How many zones? Can you tell me how many zones are there? By Meckel. So this is the urethra. Okay, this is the urethra. This is the prostatic urethra. And there are 3 zones around the thing. This is the first zone. Okay, this is the first zone. After that, there is second zone. After that, there is last zone, 4th zone. What is this green color zone known as? Can you tell me? What is this zone known as? Very important. Peripheral zone. Why this zone is very important? Can you tell me? Why this peripheral zone is very important in prostate? For as a surgeon, why should I worry about it? Very good. It is a cancer causing zone. Very good. It is a cancer causing zone. Peripheral zone is cancer causing zone. And what is this blue color drawn zone? The periurethral zone. What is it known as? Again, around the urethra. What is this zone? Why surgeons, we are very much concerned about this zone? What zone is it? It is a transitional zone. Very good. It is transitional zone. This is the zone involved more in benign prostatic hypertrophy. Now the question comes, if I am going to do TURP for all the old fellows in the country, will it reduce the risk of cancer? No, because cancer is common in peripheral zone. In TURP, I will be coring out this tissue only. In TURP, I will be coring out the transitional zone. Cancer is very common in the peripheral zone. And what is the central zone known as? It is known as central zone. This is central zone, not much significant. This is central zone. So please remember, prostate is divided into 5 lobes by the anatomy people. So as surgeons, we are least bothered about the anatomical lobes. We are only bothered about the zones. Transition zone, central zone, peripheral zone. Peripheral zone produces cancer. Transition zone produces benign prostatic hypertrophy. Okay. So the normal size is 25 ml. 25 ml is a normal prostate for an young adult. So number 19, Hydatid cyst image of the kidney is given. State the wrong one. State the wrong one. FNAC or biopsy required. So this is I don't know whether this is an image question or something else. Is it a question on image of CT scan or some image of kidney itself asked in the exam with the Hydatid cyst? It's image CT. Okay, that CT means this is a perfect image showing you a Hydatid. You can see there are multiple daughter cysts like this. So it is a classical Hydatid CT. No need of FNAC or biopsy. In fact, if you try to do biopsy, you will leak the cyst and can cause anaphylaxis. Always albendazole is given preoperative and it is caused by doc tapeworm. What is the latest treatment for this type of cyst? It is nothing but PAR. PAR is possible only in liver and kidney. PAR is contraindicated in lung and brain. Can you tell me the reason? Very simple reason is that. It is a reason based on microbiology. PAR is possible only in liver and kidney. It is contraindicated in lung and brain. Percutaneous aspiration, infusion, reaspiration. It is because, very simple, only in liver and kidney they have a ectocyst, which is nothing but what? Also known as pericyst. Yes, this pericyst is derived from the host tissue. Derived from host tissue. This lung and brain will have no ectocyst. When I try to do puncture, it may rupture outside and it can disseminate. So we don't do in lung and brain. It is possible only in liver and kidney only. Okay, so please remember percutaneous aspiration, infusion, and re-aspiration is nothing but pair. Frostbite is a recently repeated MCQ. Frostbite is nothing but a cold burns. Please remember, people living in the Kashmir and other places, they get trapped in an ice. They get their legs or feet trapped in an ice, or they are exposed to extreme negative temperatures. They will develop frostbite. Is nothing but a cold burns in the foot, fingertips. And it will go for the same 4, stage 1, stage 2, stage 3, stage 4. They will even go for gangrene of the fingers. Antibiotics and dressings are not used. That is true. Just you have to maintain it healthy. No need of antibiotics. Rewarming not done is wrong. We have to do rewarming. Bailey says rewarming should be done at what degree centigrade? Rapid rewarming at 42 degrees centigrade. Please remember this point from Bailey. This question is from Bailey. So these examiners have covered questions from Bailey, Sabiston, Swartz, self-practice, ward rounds question, everything they have made in this paper. It is a very good paper to read, not to write. Okay. So may need an amputation. May need an amputation. Yes, they will need an amputation, but it will be a delayed amputation. After some time, we will do it. A delayed amputation will be done. Not immediately, after some area. Yes, clean and dry area. That should be very good. Thanks for calling. Clean and dry the area is correct answer. Clean and dry the area is correct. So that is nothing wrong. That is correct. Clean and dry the area is correct choice. So frostbite occurs in fingers, toes, cheeks, tip of nose and ears when the frozen tissue feels hard and cannot be indented. So rehydration with warm fluids, non-steroidal anti-inflammatory drugs, wait for demarcation, and we can delay it. Definite surgery to excise the tissue can be left for even many months. After many months also we can do, but keep a clean, dry area. Recently, tissue plasminogen activators, nerve blocks are all have been helping in reducing the amputations, but have to be started within 24 hours and are seldom possible in the field. Okay. Very, very impossible to do all these things within 24 hours. That's what they are telling. So there is a question number 21. I couldn't get the exact images, but I can get the concept what they are asking. So there are 4 X-ray chests given in the image. All are cases of blunt trauma to the chest. In blunt trauma to the chest, ICD is an interesting, important procedure done. It is done for the following cases only. First point, please remember where it is done. It is done for pneumothorax. Whether it is a tension or open or suction, any type of pneumothorax, ICD is done. Hemothorax, when there is a bleeding into the thoracic cavity, I should put a hemothorax, I should put an ICD. When there is a pleural effusion, I should put a intercostal drainage tube. ICD, before putting, you should be very careful. You should not put in number 1, diaphragmatic hernias, because many times we think that is a collection and we put the tube, no, it will go and perforate the bowel. So diaphragmatic hernias, ICD will be put, but after doing a CT scan. Flail chest. Flail chest is not useful. It is not going to help you in ICD, is not going to help. In flail chest, our main aim is to rule out pulmonary injuries. To rule out any pulmonary injuries is our main aim. So I should rule out pulmonary injuries. So I should take a CT scan. I should do a CT chest in all these cases before planning a procedure. Diaphragmatic injury, flail chest and all, I should do a CT scan of the chest. So these images might have been given in the exam. So they would have given a flail chest image of multiple rib fracture by chance. Diaphragmatic hernia, most commonly on the left side, they might have given. Okay, these 2 images cases, we don't put an ICD immediately. We will do a CT scan before proceeding to ICD. That is a very important question. Question number 21. So there is one more question which I got the recall just few minutes before starting the session. Rectal prolapse operations. Rectal prolapse surgery. Please remember rectal prolapse surgery. Abdominal approaches, what are the names? Perineal approaches, what are the names? Abdominal approaches are Wells rectopexy, Ripstein, and Frickman Goldberg. This is being a repeat MCQ. This question is being asked 100 times before an INI was introduced. So in AIMS exams, Wells, Ripstein, Frickman, Goldberg. Frickman, Goldberg, we do resection. Please remember, resection of sigmoid colon done. In perineal procedures, which are all done, Thiersch, Delaarme, Altemeyer. Altemeyer is a procedure where you do resection of sigmoid. So perineal procedures, Thiersch, Delaarme, Altemeyer. Abdominal procedures are Wells, Ripstein, Frickman, Goldberg. Now you would have understood this is another important focused area for national board exams. So like this, you have to focus on the important questions. I don't know any more question I'm missing, but around 22 questions, 20 questions, I think are straightforward surgery questions. We might be having some overlap with other subjects. Let us do a complete session once all the recalls are done fully. So this is a very small session. I thought of giving a fast review because you'll be fresh and out from the exam hall. You'll be waiting to know the correct answers. This video will be available in YouTube in DocTutorials as well as in my page, in my YouTube page. And you can follow me on Instagram and Facebook Surgery 6 Group for future questions. Any doubts you have, please tell me. I'm just here to clear some of your doubts. It is going live in YouTube also. There are some students watching there. Any doubts you have, please tell me. I'm also watching the students in YouTube. Sorry, students from YouTube, I could not answer your chat directly because I was more doing this thing here in a Zoom. Yes, I think there is no doubt in. Okay. The need postponement confusions, please keep preparing as if the exam is as scheduled, because you know very well about the national board guys. They will postpone if at all needed only 1 week before the exams. Last time also they did only 10 days before the exam. After applying the centers and all, they did that. So please don't worry about it. Please keep reading. Just do MCQs. Many times, what happens? The last 15 days of exams, what you are reading for the last 15 days, it is not going to help for the exam. Even in this paper, you just think about what you have read in the last 15 days. Nothing would have helped in this 200 questions. Whatever you are going to read in the last 15 days is not going to help anything in any exam. So whatever you have read 6 months back, 3 months back, from that old recall memory only, you would have been answering most of the questions. So please, therefore, don't get stressed. Just relax. If you could possible to read and revise, you read. Otherwise, just go cool. That is enough to crack the exam, whether it is going to be postponed or preponed, anything. The last few weeks of calmness is very important to crack the exam. Okay, don't worry. It is the same situation for all the 1,75,000 students who are waiting there. Everyone is having the same stress, whether it will be postponed or not. The one who is going to come out of this stress very casually and going to appear for the exam, whether it is preponed or postponed or on time, is going to win the seat in this exam. The extension of the exam is not going to help. Even if it is going to be extended 2 months, that again 1 month, what you are going to read is not going to be helpful. Whatever you are reading for the last few months is going to help in the last moment. So all the best, do well. So see you in another session. Okay, thank you.